We talked about several things, including surgery, including radiation therapy, including chemotherapy. Our goal in older people is to give them the best therapy, but not necessarily the most therapy, which isn't always the best, and to try to achieve the same results with less side effects and toxicity. So in radiation, we talked about a subset of patients who might not need radiation. These are women with small cancers, small breast cancers that are hormone receptor positive, that can have a lumpectomy, have clear lymph nodes, and who can take endocrine therapy. We talked about minimizing surgery, especially axillary node surgery, unless there's a really good purpose in the patient's care, and many of the older women are not going to benefit from this type of treatment. And then we last talked a little bit about chemotherapy, which is frequently a difficult decision in older patients. Frequently they have a lot of comorbidity, a lot of other illnesses, and how to optimally select chemotherapy. Where is it appropriate to use it? Where is it iffy? And where shouldn't we do it? I think the issue is we're fixed on age. So when we talk with each other, we say this is a 75-year-old woman with breast cancer. And really what we should be saying is this is a woman with an estimated life expectancy of 15 years with breast cancer, and get the age out of it. And then we can kind of think what type of breast cancer she has, what's the risk of it coming back. It can be a very aggressive, like a triple negative breast cancer or a hormone receptor negative, HER2 positive breast cancer. And those women with good life expectancy should be treated with state-of-the-art therapy, provided they don't have any serious heart or other disease. And those women who are frail and vulnerable, one might even eliminate chemotherapy in some of them, but they're going to have a very short life expectancy. So we've got to get away from the age and get more into what's the life expectancy, what are the goals of the patient, and what are the potential absolute benefits of treatment and its side effects. So I think if we get it right, we'll be saving more older women with early breast cancer, because what we've learned, at least from the United States, and I'm sure it's true in the UK and in Germany, is that if you look at how women have done over the last 20 years with breast cancer, there's been a dramatic improvement in survival. But the older people haven't shared as much in the good news as the younger people. They've benefited. And we believe a lot of that is because they've been lowballed with therapy. They haven't had enough endocrine therapy or chemotherapy. This isn't to say they all need to be treated, but historically, we undertreated them. And I think the message is, let's get it right. Is this a healthy person? What's their life expectancy? And then what are the absolute benefits? And then tell that to the patient, see what they think of the side effects. And we all have to make a decision at the end and advise them whether to be treated or not.